Hello, my name is Jessica Barron. I'm a second-year medical student at the Florida Atlantic University Charles E. Schmidt College of Medicine. Today we will be discussing a rare presentation of childhood onset granulomatosis with polyangiitis as a palatal defect. Granulomatosis with polyangiitis is a necrotizing systemic vasculitis of small and medium-sized vessels that presents in the 4th or 5th decade of life with nasal, pulmonary, and renal involvement. GPA is rarely seen in childhood. However, when it does present in childhood, it will present with more severe symptoms and a worse prognosis. Moving on to the case report, for the history of present illness, we have a 16-year-old female with a history of recurrent epistaxis, chronic nasal congestion, and recurrent otitis media, who presents with nasal regurgitation of food and liquids for several weeks. She also had night sweats, a 30-pound weight loss for several weeks, headaches, blurred vision, loss of smell, and an inability to tolerate solids and liquids except through a straw. The physical exam, the vitals were largely unremarkable. We found a 3 centimeter defect on the right side of the posterior hard palate and anterior soft palate with no surrounding erythema or ulcerative lesions. This is shown in figure 1. There was also a tympanic membrane perforation. Her left and right eye vision was decreased at 20 out of 200 and 20 out of 400 respectively. She was unable to differentiate the color red, which was worse in the right eye. The nares were congested with a foul odor and bilateral blood clots were found. The skin was shown with deep ulcerations that were observed at the top of the umbilicus and left upper arm, and some superficial ulcerations that were observed along the labia majora and perineal regions. Laboratory tests, bronchoscopy revealed diffuse airway bleeding with erythematous friable mucosa in the bronchioles. Chest x-ray, as shown in figure 2, found extensive cavitary opacities in the upper and lower lungs bilaterally, with the largest mass measuring 6.9 centimeters in the right upper lobe. CT and MRI of the sinuses found extensive sinonasal destruction, and there was a right orbital abscess that was noted to test positive for Staphylococcus aureus and group B streptococcus, both with wide antibiotic susceptibility. And the nasal biopsies revealed diffuse necrotizing vasculitis with foci of granulomatosis inflammation. And GPA was confirmed with pathognomonic X-ray chest lesions and biopsy results. The patient tested positive for C. ANCA. In figure 3, there are some laboratory tests. The white blood cells are elevated, and the hemoglobin is decreased, indicating anemia. The renal ultrasound was unremarkable. However, there were some 2+ leukocyte esterase and blood in her urine, and the neutrophil oxidase burst assay showed normal neutrophil function. So going out to the clinical course, on admission, she received ampicillin, sublactam, and for 3 days of pulse steroids due to suspicious of GPA prior to biopsy confirmation. Then the patient was intubated for the bronchoscopy and biopsies. The patient remained intubated because of the extensive sinopulmonary destruction that was found on the imaging of the CT and the MRI. And then the patient was placed on rituximab, prednisolone, and prophylactic antibiotics and was discharged on hospital day 7. And she was instructed to regularly use saline irrigation and mupirocin rinses and gels to reduce sinus symptoms. And the ENT follow-up was 2 weeks later, and the patient noted improved vision, continued nasal regurgitation, and continued nose crusting. So this case is very unique given the rarity of childhood onset GPA with the atypical presentation of nasal regurgitation. The patient first presented with a palatal defect and did not present with the typical sinopulmonary and renal involvement that GPA is known for. Instead, she presented with only the palatal defect, and upon further questioning, there were more symptoms such as the recurrent otitis media infections and so on. And this patient also did not have the other typical symptoms of GPA, such as strawberry gingivitis, cough, hemoptysis, pleuritic pain, or dysuria. Thank you so much for listening.